Hi, everybody. Welcome back. Well, I have the tremendous pleasure of introducing our next presenter, Laura Zitella, who I've known for several years, have had the pleasure of attending many of her presentations at a number of different conferences. And so, Laura, I've known her at Stanford, and now she's at UCSF in San Francisco, obviously. And she's a nurse practitioner there, is extremely skilled and has tremendous knowledge of all of the topics she specializes in. And today, she's going to be speaking on meeting the many challenges of AML, oncology nurse tactics for a complex disease in an era of novel therapies. Welcome, Laura, and it's all yours now.
Hi, everyone. I'm really happy to be here with you today. And Tim, thank you so much for the invitation. It's great to be joining this virtual presentation. First, I'd like to thank PeerView Live, which is an amazing educational company who has coordinated and supported this presentation. And I'd like to thank all of you for being here today. We've had such wonderful presentations, and now we're in the home stretch, and we're going to finish strong. So my disclosures are I served on an advisory board for Merck. There are no planning committee disclosures. And we won't be discussing much off-label use. If I do mention off-label use, I will let you know. And then housekeeping notes. We just wanted to thank you for taking your time out of your busy schedule to attend this virtual CNE activity. And we also want to thank Abby, Bristol Myers Squibb, and Jazz Pharmaceuticals for making this event possible through the provision of educational grants to support this activity. You should have received a link to an online post-test and program evaluation. In order to receive CNE credit, you must complete the online post-test and evaluation at the conclusion of this meeting. Your evaluation of the program is very important in helping us better meet your current and future medical education needs, and we welcome your opinions and your comments. So let's get started with the presentation. AML is not a common malignancy, but it is the most common acute leukemia. There's nearly 20,000 cases estimated for the year 2020. Now, this is the disease of older patients. Most patients are older at presentation, and the median age is 68. However, we have patients of all ages that we treat with AML. And so there are patients in their 20s, 30s, 40s that unfortunately also develop this disease. However, older patients tend to be undertreated. And although they can benefit from really intensive therapy, as a group, they generally have lower CR rates than younger patients. They are more likely to relapse. They have decreased survival. And unfortunately, they tend to have more morbidity and mortality from treatment-related side effects. So the symptoms of acute myeloid leukemia. Acute myeloid leukemia is a malignancy of the white blood cells. And so the symptoms that we see when patients present tend to be hematologic symptoms like neutropenia, so a low white count or a very high white count, fevers due to infection from the abnormal white blood cells or tumor fevers, anemia, thrombocytopenia, or less commonly an enlarged liver or spleen. So when patients are first diagnosed, there's a lot of education that goes into it. I think when I think about AML, I think there's two main ways that patients present. Sometimes patients are younger and they present, they're totally healthy and they have a cold that doesn't go away after a couple of weeks, so they're feeling really tired and they present and they have an abnormal CBC and they're suddenly told they have AML and they have to be admitted to the hospital and they're going to be there for a month. So it's really life-altering and really sudden. And then another common presentation is in an older patient who possibly has a pre-existing MDS or other pre-existing myeloid disorder that's more low grade and eventually evolves into AML. And so this tends to happen a little bit more gradually. So when patients are first diagnosed, it's really overwhelming, and we need to talk to them about what is going to happen. Obviously, patients are used to us doing a history and physical and asking about their medications and drawing labs like a CBC with DIF and a chem panel and coagulation studies. Some patients will need a CT or an MRI or a lumbar puncture, but most patients with AML do not have these studies routinely. We only obtain these studies if a patient has symptoms that would lead us to suspect CNS disease. CNS disease is not common in AML like it is with ALL. And then patients who are younger and who are potential candidates for transplant need to have HLA typing right at the start of therapy. And then lastly, bone marrow biopsy and cytogenetics. And this is a really important thing to talk to patients about. I had a patient who was treated recently, and after the completion of her treatment, she had journaled throughout her experience, and she wrote a book. And when I read the draft of what she wrote, I was really surprised to see how vividly she remembered every single detail of me walking into the room to do her first bone marrow biopsy and what that was like for her. The bone marrow biopsy is a really uncomfortable procedure for patients, and they require a lot of reassurance that we're going to be there every step of the way with them, and we will make it as comfortable as we possibly can. But the bone marrow biopsy gives us such important information. So from that, we can determine if they have cytogenetic abnormalities or molecular abnormalities. And really, the cytogenetic abnormalities associated with the disease and the molecular abnormalities help us understand the prognosis for that particular patient, but also guide treatment. And we're going to talk about some of the targeted treatments that we have for AML now. It is also important to explain to patients that these tests do take some time to result. So currently, we can turn around a lot of the tests in just 2 to 3 days, which is good so we can start therapy. But most major academic centers are also now doing next generation sequencing for AML. And this gives you an entire panel of genes and can pick up a lot of different types of mutations. And AML is characterized by an incredible variety of mutations. So this is really important, but these tests usually take about 2 to 3 weeks to result. And then lastly, anthracyclines are often a part of intensive induction therapy. And so patients will need to have a echocardiogram to check the ejection fraction prior to starting any cardiotoxic therapy. So older patients can tolerate intensive therapy. As I mentioned earlier, often older patients are undertreated, but we have to be really careful not to have an age bias because an older person who is fit can tolerate intensive therapy and should be treated with the maximum intensive therapy that they can tolerate. So my colleague Sarah Tinsley from Moffitt Cancer Center did this really important quality of life study. And she looked at quality of life of older patients with AML who underwent intensive chemotherapy. And she told me that honestly, she thought that the results of the study would show that the quality of therapy went down with treatment, but that's not what happened. Her results showed that the quality of life actually went up when they had therapy. And part of that is probably because AML can make you feel so bad and patients are so symptomatic that once they get through the intensive therapy, their quality of life will increase because we have improved the disease status. So when you're trying to decide about which patients can have intensive therapy, there are some tools that you can use to calculate the likelihood of a patient dying from treatment. And the two tools that I've used are the AML composite model and the Fred Hutchinson model. And these basically take into account the patient age and comorbidities, and it'll give you a percentage probability that they would die within 30 days of treatment. Now, I don't use this actually in clinical practice with patients unless patients specifically want to know numbers, but usually patients don't specifically want to know numbers. But I think these tools are really helpful for research purposes, and I also think they're helpful for our own education, just to have a sense, because I think sometimes we underestimate how toxic a therapy might be for a patient. And so this is a good evidence-based way to just sort of check yourself when you're making estimates in your head. The other important issue in AML is palliative care. And we're talking about palliative care in AML so much more now. So this is a study that was just presented at the 2020 ASCO meeting, and it looks at integrating the role of palliative care with treatment, so that that patients are receiving palliative care along with their potentially curative therapy. And patients who had palliative care initiated at baseline with their anti-cancer treatment had a significant improvement in quality of life, psychological distress, and also end-of-life care. So another colleague of mine, Elise Button, who is a nurse researcher in Australia, has a similar view about palliative care. And this is a model that she came up with where palliative care is instituted along with curative care until completion of therapy. And at completion of therapy, then either there's bereavement care if the patient has passed, or survivorship care for patients who survived. But it's really important to talk about palliative care, symptom management, quality of life, and have palliative care involved, especially because although we're going to talk about a lot of exciting new treatments, AML still is a very grim prognosis, and most older patients will not survive. And so they will ultimately require end-of-life care. So let's start with our cases. This is an older patient who has AML with myelodysplastic related changes. William is 75 years old, and he's lived a very active life despite his recent diagnosis. He's been married for 40 years. He has 3 children and 7 grandchildren. During his diagnostic workup, the MDS panel that was drawn showed a deletion 5q. So this indicates that even though he's newly diagnosed with AML, and we didn't know that he had a prior blood disorder, that he has the diagnosis of AML with myelodysplastic changes. So the diagnosis of AML with myelodysplastic changes means that in the bone marrow, there are changes that are typically associated with myelodysplasia. However, this can either, it can be a new diagnosis, or it can occur after a patient has already had MDS for a period of time. His performance status is excellent, and he's really anxious, understandably, over his diagnosis. And he wants to learn more about his treatment options, and he really wants to pursue aggressive treatment. So let's talk about the nurse's role as educator and advocate. It's really important that we are always honest, and we let patients know what their treatment options are and what the likelihood of is that the treatments are going to offer a long progression-free survival. So AML with myelodysplastic changes is a really challenging type of AML, and we're going to talk about the different cytogenetic abnormalities and what that means in terms of prognosis on the next slide. But the fact that he had deletion 5q means that it puts him in, unfortunately, a poor risk category. So what we would say to him is that although it's certainly hard to treat, we have treatment options, and there are intensive options and there are less intensive options, and we're going to talk about both of them. And of course, it's really important to include the family, because it's not just the patient going through it, it's also their entire support network. And to also talk to them about other support that's available, like especially the Leukemia and Lymphoma Society does so much for leukemia patients. All right, so this is a very simplistic way of looking at AML. There are a couple subtypes that actually have a really good response to chemotherapy, and they can be potentially cured with chemotherapy alone. And those are listed here. Those are the core binding factor leukemias and AML with NPM1 or CVPA mutation. The AML subtypes that have a very poor response to chemotherapy are any AML that has adverse cytogenetics, any AML that has the FLT3 mutation, a secondary AML, meaning a treatment AML. So for example, a patient with breast cancer who ultimately develops AML from her prior chemotherapy treatment. And then the AML with the myelodysplasia changes, which is what William has. And then, of course, older patients. And the significant difference between these two populations of patients is that the patients who have a type of AML that has a good response to chemotherapy, their overall survival is about 65% versus the poor prognostic factors where the overall survival is only about 15%. The other thing I wanted to let you know is that the American Society of Hematology just released new guidelines for older patients with AML, and this is the first time that they've had guidelines like this. So I put the link on this slide because they're really helpful, and I hope you'll take a look at them. Okay, so for William, our options are going with conventional chemotherapy, which would be 7+3, which is 3 days of an anthracycline and 7 days of cytarabine, which is the standard of care in AML in terms of intensive therapy, and it's been that way for almost 50 years. And then there is a newer drug, CPX-351, which is a liposomal formulation of 7+3, followed by hematopoietic transplant or venetoclax-based therapy. So William decides that he was actually interested in pursuing the transplant option. And so we are preparing him to receive induction with CPX-351. So CPX-351 is a really, it is a way that we have made conventional 7+3 better, basically. It's a liposomal formulation that are the same drugs as 7+3, daunorubicin and cytarabine, but this liposomal formulation keeps the ratio of daunorubicin and cytarabine fixed. And so this is a very synergistic ratio, and it lasts for a very long time in leukemia cells. Because it still includes an anthracycline as a component of this drug, it's really important to be mindful of the lifetime anthracycline dose. And it's also important that patients have their ejection fraction checked prior to therapy. But this is a drug that was approved in 2017, and it is approved in patients who have a secondary AML, like William does. All right. This is the Kaplan-Meier of the results from the phase 3 study that compared CPX-351 versus 7+3. And you can see here there was a significant improvement in the overall survival in these patients who had a high-risk AML. But what is even more impressive is that more patients who received CPX-351 were able to proceed to transplant. And the patients who had CPX-351 and then had a transplant also had significantly improved overall survival. So this is really exciting data, and this was the data that the approval was based on. The side effects of CPX-351 are really similar to 7+3. So any patient undergoing AML is going to have neutropenia, high risk for infection, likely to have febrile neutropenia. They'll be anemic, requiring transfusions, and thrombocytopenic, requiring platelet transfusions. The one significant difference about CPX-351 compared to standard 7+3 is that there is a delayed count recovery. So we do see that rather than counts recovering between days like 14 and 21, often it takes longer, between days 28 to 35. So you will see a delay count recovery with CPX-351. So while these patients are pancytopenic, it's really important that we talk to them about neutropenic precautions, that in general they avoid fever-reducing medications so that we know when they have a fever, we don't want to mask it. If they have a fever, it's treated as febrile neutropenia. And these are high-risk patients that would generally need to be admitted. They can't be treated as low-risk febrile neutropenic outpatients. In addition, patients need frequent transfusions. And so these patients, whether if they're inpatient, they're getting labs checked every day. If they're an outpatient, they're getting labs checked 2 to 3 times a week, and transfusing for hemoglobin of less than 7 to 8, or a platelet count of less than 10, unless they are bleeding or are undergoing some sort of procedure where we need to have a higher platelet count. So for all of these patients, I like to use a calendar. I think it really helps the visual of what to expect and when their counts are going to be low, to just show them the days that they're going to receive treatment, and then also the days that I expect their counts to be low, and when we expect count recovery, and when we will do the follow-up bone marrow. So for CPX 351, often the induction is done as an inpatient, although some centers have started doing it as an outpatient, and then admitting if a patient develops febrile neutropenia. But in general, most of the consolidation cycles are now done as an outpatient. Please reassess your understanding of efficacy outcomes with CPX 351 in high-risk AML, including patients who went on to receive stem cell transplants. Okay, so it looks like those of you that were not familiar with this before feel like we have reviewed it such that you have some understanding of it now. So we're going to move on to a different case. This is an older patient who has an intermediate risk AML. So intermediate risk is not in the good risk category or the poor risk category. This is usually a patient who has normal cytogenetics and does not have the FLT3 mutation. So Alex is 65, presents with pancytopenia, and has an intermediate risk AML. He's very fit, he's been a lifetime jogger, does not smoke, and he has an excellent performance status. He really wants to pursue aggressive therapy, but unlike William, he does not want to undergo a hematopoietic cell transplant. So after initial consultation, since Alex is younger than William, conventional standard 7+3 was recommended. And he responded really well to chemotherapy and achieved a complete remission. Unfortunately, we know that without consolidation, most patients with AML will ultimately relapse. So he undergoes 1 cycle of intermediate dose cytarabine. We now have a new option for patients who have achieved a complete remission following intensive therapy. And this was just approved actually about a week ago. CC486 is an oral formulation of azacitidine. Azacitidine is a hypomethylating agent that previously has not been available orally. So there was a phase 3 trial called the Quasar trial, where this agent was used as a maintenance therapy, and it was compared against placebo in patients older than 55 who had AML in the first complete remission. And this Kaplan-Meier curve shows you that the use of oral azacitidine significantly prolongs overall survival versus not doing any type of maintenance therapy at all. And it also improved the median relapse-free survival. Importantly for our patients, the quality of life was the same, whether they were taking oral azacitidine or a placebo. So the side effect profile was extremely tolerable. Most of the side effects that we saw with oral azacitidine are nausea, vomiting, diarrhea, or constipation. And so it is really easy to pre-medicate patients with a 5-HT3 antagonist prior to dosing, using Imodium for diarrhea and laxatives for constipation. Which of the below AML patients do you now think is an appropriate candidate for treatment with oral azacitidine? I'm not sure. A patient with de novo AML and a FLT3 mutation, a patient with AML who has not achieved a CR after induction, a patient with AML that has achieved a complete remission, who's eligible for intensive curative therapy, and a patient who has newly diagnosed TP53 mutant AML. Okay, wonderful. So oral azacitidine is only approved at this point after a patient has already received AML and has achieved, a patient who has achieved a complete remission after intensive therapy in the maintenance setting. Our next patient is Michelle, who's a 76-year-old, and she has a normal karyotype AML and no FLT3 mutations. So it's an intermediate risk. And she also does not have an IDH mutation. So she doesn't have any mutations for which we have targeted therapy. Her white blood cell count is elevated at 26. She is neutropenic. Her ANC is 500. Her hemoglobin is 5.7 when she presented, and her platelets were 23. She has a past medical history of hypertension, and her performance status is not that great. She's a widow with no children, and she lives alone, but she's active in her church. She's somewhat health literate, but as most patients are, she does have some anxiety over her diagnosis, and she feels like she's run out of options because of her age. She's really concerned about how she's going to handle therapy for her AML. So let's talk about what kind of treatment options Michelle has. So first of all, talking to patients about this is an excellent example of how helpful it is to engage palliative care early on in the disease process, because the AML that Michelle has is treatable, but ultimately it is not going to be curable. And so being honest about how our goal is to help her live as long as possible, as well as possible, and that all of the treatment is to prolong her life as much as we can. It is also important to mention that there are other intensive therapies, but that there are certain therapies that would not be recommended to her because we would worry that they might actually shorten her life because of morbidity from the treatment. And the goals of therapy in this situation are really to achieve remission and improve quality of life. So some of the lower intensity treatment options for Michelle include low-dose cytarabine or hypomethylating agents like azacitidine or decitabine, and then targeted agents like venetoclax plus a hypomethylating agent and glastigam. And really at this point, venetoclax and hypomethylating agents are now the workhorse of all treatment of AML for lower intensive therapy. So this is a regimen that is being used really quite frequently now. And this is based on the phase 3 BIALI trial where venetoclax and azacitidine showed an improvement in overall survival versus azacitidine alone. So we've heard a lot about venetoclax today. You've heard about it in CLL, and some of the other speakers have already talked about how venetoclax is a BCL2 inhibitor, and it works on B-cell malignancies, but it also affects myeloid cells as well. So it's been a really effective agent that we now use in AML. Based on the experience in CLL, all of the trials with AML were designed specifically with a algorithm to prevent tumor lysis syndrome. So first of all, it's important that the white blood cell count is less than 25. And if it's not, then you can use Hydrea to bring the white blood cell count down. In addition, just like with CLL, there's a ramp-up dosing, although with AML, the ramp-up dosing, which I'm going to show you on the next slide, is actually much quicker. Venetoclax tablets should be taken with food and water about the same time each day. They can be swallowed whole. You should not crush or break them first. And venetoclax can be started prior to initiation of, venetoclax can be started before you get the biomarker or cytogenetic testing back. Although we often do wait for many of the results to come back because we usually get them within 2 to 3 days. And it's safe unless the patient has a hematologic emergency to wait until we get those results. And then it's important to assess the individual risk of tumor lysis. And we're going to talk in the next couple of slides on how we do that. All right, so this is the venetoclax dose schedule in AML, and you can see that the ramp up is pretty quick. On day 1, it's 100 milligrams. On day 2, it's 200 milligrams. And day 3, it's 400 milligrams. And then 400 milligrams is the recommended dose when combining venetoclax with azacitidine, which is a hypomethylating agent. If it's being combined with low-dose cytarabine, which is not a preferred regimen, then you increase it to 600 milligrams daily. So patients should be educated about tumor lysis because they need to really be drinking a lot of fluid. We recommend that they're drinking 2 or 3 liters of fluid daily. We also encourage them to limit foods and fluids containing extra potassium and phosphorus. And then we assess for risk factors like circulating blasts or a high burden of leukemia involvement in their bone marrow, an elevated pretreatment LDH, and reduced renal function. So this is the algorithm that is used to prevent tumor lysis with venetoclax. So as I mentioned, cytoreduction is necessary if the white blood cell count is greater than 25,000. The white blood cell count has to be less than 25,000 before you start therapy. Then assessing individual risk, and patients are put on allopurinol as prophylactic. If they have reduced renal function or they have an elevated uric acid to start with at baseline, you can consider using risperidone to bring their uric acid down rapidly. Risperidone will decrease the uric acid within 4 hours, whereas allopurinol just prevents new uric acid from being made, so it won't lower a baseline elevated uric acid. And then the blood chemistries that we test for tumor lysis include potassium, uric acid, phosphorus, calcium, and creatinine, correcting any pre-existing abnormalities, and then monitoring. So with every dose increase, you have to check all of these electrolytes pre-dose, 6 to 8 hours after each new dose, and 24 hours after. And with the CLL patients, when we first started using venetoclax, we used to admit them to the hospital for their first dose. That is no longer done because we're so vigilant about monitoring for tumor lysis. So this can be done in the outpatient setting. And with the tumor lysis precautions, in the clinical trials, there were no patients that had any clinical tumor lysis. There were a few patients that showed some laboratory abnormalities consistent with laboratory tumor lysis, but the risk of tumor lysis is extremely small in these patients if all of these precautions are followed. The major side effect that we really struggle with venetoclax is myelosuppression. So it is an on-target effect that venetoclax causes neutropenia. And with these patients, if they have not achieved a complete remission, like when they first start taking venetoclax, we will continue the venetoclax through the therapy, or through the neutropenia. And after they have achieved a complete remission, then if they have neutropenia, then you can hold the venetoclax and give growth factor, and then resume the venetoclax. If they continue to have episodes of neutropenia through subsequent cycles of venetoclax, then you would hold the drug, give growth factor until the neutropenia resolved, and then you can dose reduce. Like, for example, you can give it on day 1 to 21 of a 28-day cycle. Lastly, on venetoclax, you want to be careful about CYP3A4 inhibitors, especially like azoles like posaconazole, because there are significant drug interactions, And there are very specific dosing modification recommendations. Okay, our last case, because we only have a few minutes left, is a 60-year-old woman with newly diagnosed AML. She presents with fatigue, pre-syncopal symptoms, and night sweats. Her white blood cell count is 75,000. That's really, really high for AML. Hemoglobin is 7.6. Platelets are 22, and the testing confirms a FLT3 mutation. Although she's fit, she had a back injury, so she is retired. She's divorced and has no immediate family. And unfortunately, she has a very poor health literacy. She doesn't fully understand the effects of AML, including the blood-related symptoms. So again, we would talk to her about prognosis. And in this case, the FLT3 mutation is a really serious mutation in AML, and it carries a pretty grim prognosis. But fortunately, there are some new therapies that we can treat her with. So it's important that we develop a plan for educating her, explain the results of the FLT3 testing, and then talk about some of the treatments that we have available. So first of all, the FLT3 mutation, patients who have an AML with the FLT3 mutation, most of them present with a higher white count than is usual with AML. It has a worse prognosis, and unfortunately, the disease is more likely to relapse. But we do have some new drugs. So midostaurin is currently approved for newly diagnosed AML in combination with 7+3, and that improves overall survival versus chemotherapy alone. The second drug is gilteritinib, and it is improved for relapsed and refractory AML. And actually, this has been a really important addition to the FLT3 inhibitors. Sorafenib is also used, but that's off-label. It's not approved for this indication. And for those of you who have used sorafenib for other malignancies, you know that there are a lot of side effects associated with it. So that's really fallen out of favor. And quizartinib is approved in Japan, but it has not been approved in the United States. And unfortunately, there's some serious toxicity associated with it. So the next question is, please reassess your confidence in your ability to counsel patients on the nature of ramp-up dosing with venetoclax in the AML setting. Okay, so moving on to Emily. She is a candidate for 7+3 plus midostaurin, followed by an intermediate dose ARC. And we need to talk to her about what to expect with the FLT3 inhibitors. So first of all, with the FLT3 inhibitors, we need to watch for GI toxicities. All of the FLT3 inhibitors are moderately emetogenic, and so usually we pre-medicate the patients with a 5-HT3 antagonist prior to each dose. Diarrhea is also a possibility, and once you've ruled out infectious diarrhea, it's okay to use Imodium. And then, of course, a low residue diet and encouraging fluid intake. These medications all have drug-to-drug interactions, and azoles are always a culprit, so it's really important to check for drug interactions and make dose modifications. We often will not treat with an azole initially when we start a FLT3 inhibitor. And they cause QTC prolongation, so it's important to periodically check ECGs to monitor the QTC. Other side effects include skin rash, particularly with midostaurin and with sorafenib. Sorafenib can cause a hand-foot syndrome, and midostaurin does cause a rash. So emollients can be used. And then lastly, one side effect we don't have on here but is important to talk about is gilteritinib is more myelosuppressive than midostaurin. And so it's important to monitor for neutropenia and to hold the dose should neutropenia occur. And then lastly, with gilteritinib, is that it can also cause a differentiation syndrome. And on the next couple slides, we're going to talk about differentiation syndrome, which is a side effect of another class of drugs that we use for AML, and it's treated the same way. But basically, anytime you have a drug that causes immature blasts to differentiate or to become more mature, it releases cytokines, and those cytokines can cause a differentiation syndrome that is treated with steroids. Okay, so what if Emily had been a less fit patient and presented with an IDH mutation? There are agents now that target both IDH1 and IDH2. And IDH is basically an enzyme that's in the Krebs cycle. And these are present in about 15 to 20% of all AML. And what it does is that mutant IDH blocks differentiation. So it causes an increase in immature blasts. And therefore, if you inhibit the mutant IDH, then you will cause differentiation. So the two agents that are approved are ivosidenib and enasidenib. And they are both approved for relapsed refractory AML, and they're also used in newly diagnosed AML. So ivosidenib is a IDH inhibitor to IDH1, and enasidenib is to IDH2. So the important thing about the IDH inhibitors is that they are not cytotoxic. They cause differentiation of immature blasts. So it's really important to educate patients that you need to stay on this therapy for a minimum of 6 months because it takes time to have a response. So this slide here shows you in month 1 the number of patients that have stable disease, which is in yellow, the number of patients who have a PR, which is in purple, the number of patients that have a CR, which is in red. But if you move along to month 7, you can see how so many more patients have achieved a CR from their disease, and fewer patients remain with stable disease. So the rate of complete remission continues to increase with time. And that's a really important thing to talk to patients about so that they understand that this is not going to happen right away. There are some other nursing considerations with these oral agents. They can cause nausea, and usually we pre-med with a 5-HT3 antagonist like ondansetron. They can cause diarrhea, fatigue, and fevers. We talked about on the last slide how it takes a few cycles to respond. And hematologic toxicities are common, at least during the first cycle, until they have started having a response in the AML. And then importantly, differentiation syndrome. So differentiation syndrome, as I mentioned, is a result of cytokines that are released when these cells differentiate. And it results in fever, dyspnea, and respiratory distress. And this is a really important thing to educate patients about because it occurs a median of 48 days after the start of therapy. So imagine you're starting a medication for your cancer treatment and you take it and you're expecting the side effects right away. And then let's say, 4 or 5 weeks later, you suddenly have a cough and a fever. Well, in this day and age, of course, the first thing you're going to think about is infection and ruling out infection. But it's really important that patients also know to call us because it could potentially be differentiation syndrome, which is pretty easy to treat if it's recognized early. So these are the recommendations for treating differentiation syndrome. So as I mentioned, patients present with fever, dyspnea, and respiratory distress. They often have a dry cough. They can have waking or edema. They can have effusions, hypotension, or renal failure, but those are much less common. The treatment is dexamethasone, 10 milligrams twice daily. And if you are not sure that this is what's going on, you can start the dexamethasone even while you're ruling out infection, because it's important to treat the patients promptly. Now, rarely patients will also have a high white count associated with this. And if their white blood cell count is greater than 30, then you can use hydroxyurea. And if they do have a high white count and use hydroxyurea, then it's important to monitor also for tumor lysis. Most of these patients do not have serious disease. If they do develop hypoxia, they have to be admitted. However, most of the patients, as I said, don't develop serious disease, and they can be treated as an outpatient. And in fact, often we don't even hold therapy. You can treat through this and then taper the dexamethasone slowly. So to summarize all of the new options that we have for AML, I've listed all of the different treatments on this slide here, along with the mutations that are associated with it. So if a patient has a FLT3 mutation seen with their AML, midostaurin is recommended for newly diagnosed patients, and it's given in combination with intensive chemotherapy like 7+3. And then gilteritinib is approved now for relapsed or refractory as a single agent. For a secondary AML, such as a treatment-related AML or an AML with myelodysplastic changes, we have CPX 351, which is the liposomal formulation of daunorubicin and cytarabine. And then
Laura, you have about 4 minutes left. Sorry.
Thanks.
Okay.
And then for IDH mutant AML, we have ivosidenib, which is targeted against IDH1 mutations, and enasidenib, which is targeted against IDH2 mutations. For older patients who are unable to tolerate intensive therapy, as I said, our workhorse is venetoclax and a hypomethylating agent. Glasdegib is an option, but we were a little disappointed in the results that we have seen with that agent thus far. And then for patients who have a favorable AML and who are younger going through intensive therapy, there is an option of adding gemtuzumab, which is a monoclonal antibody against CD33, and you can add that to their treatment regimen. And we did not talk about that in this presentation. Okay, so in summary, hematology and oncology nurses obviously have a vital role in educating patients about what to expect with the newer agents of AML. We have so many exciting novel agents that can be used, and this has resulted in significantly prolonged overall survival for patients. However, it's really important that we are also providing emotional support and integrating palliative care earlier on in the treatment journey. So with that, I want to thank you all for your attention. And do we have time for questions?
Yes, you have a couple of minutes. Does anybody have any questions? I think you can look down below on your dashboard to see if there are questions.
Okay, so the first question is, what's the rationale for avoiding fever-reducing meds for neutropenic patients? That's because we don't want to mask a fever. So for example, if a patient has pain and they're taking Tylenol round the clock, then that might delay their temperature spiking up to 100.5. So what we tell patients is to avoid Tylenol and ibuprofen. If they have a fever and then we start treating them for febrile neutropenia, it's okay for them to take Tylenol or ibuprofen. It's just that we don't want to mask a fever because we want to know the first sign of a fever and treat febrile neutropenia as quickly as possible. And then I have a question about, are you testing patients for COVID-19 prior to initiating induction and consolidation therapy? And the answer to that is yes, mostly. So if a patient is going into the hospital, they all have to be tested within 3 days of being admitted to the hospital for COVID-19. If they're being treated as an outpatient, they are not routinely tested unless they are symptomatic, unless, at least at our institution, unless they're undergoing apheresis for some reason. and then they get tested before apheresis. And of course, all these recommendations are subject to change as we learn more, but we are definitely routinely testing any patient before they're admitted to the hospital. And then someone says, on the question of febrile neutropenia, we offer Claritin as a choice. And I think that question might be regarding with growth factors. We often use Claritin to try to prevent some of the bone pain that's associated with filgrastim and pegfilgrastim.
Well, we've reached our time, and I want to thank you very much again for presenting, and I'm sure we'll see you again in the near future.
All right.
Thank you so much.
Take care of yourself, everybody.